Good morning, everybody, and welcome to our next Infection and Prevention Control update, Australia on a Knife's Edge. Our presenter today is Marg Jennings. Before we go any further, I'd like to acknowledge the traditional custodians on the land that we're meeting on today and pay respect to elders past, present and emerging. We've had a question come through already, and if there's any GPs attending this morning, you might know the answer to this. This is not actually in Marg's area. The question is, I need to find information on the link between Pfizer vaccination and the hospital side effects of Bell's palsy. Have a frontline worker, aged 26, with a strong history of Bell's palsy wanting to be vaccinated ASAP. So you could even type in the chat box if there's any GPs out there or anybody else who would know the answer to that question. There will be a survey pop up at the end of the session today. If you could please fill it out, and if you have any questions, please type it into the chat box. Over to you, Marg.
Okay, thanks, Jenny, and thank you everybody for getting up in time for this. Sort of feel like I'm you know, in this dark bubble. So I'm in Melbourne, and I think today we come out of the last stage of, you know, what's the news, but yeah, we had an outbreak about 4 or 5 weeks ago. Just to sort of fill you in, and I'm realising that some of the PHN that I'm discussing with today, I know that some of you are in, I hate the word lockdown, but you know, what else do you say? Confined to quarters. The correct word is just not moving around too much. So it's moving, well, the virus doesn't move, we move it. So, you know, I kind of wish people would just shut up saying, what can I do? And actually think about, what can I do to not move this stupid thing around? Okay, I think that's the way I look at it. So what had happened to us, poor old us, was that a chap had done he'd landed in Adelaide from overseas. Let's not talk about that. And he'd done his 14 days negative on all the 3 swaps, released on day, 14, flies into Melbourne to home, and 3 days later, he thinks, I think I've got a bit of a sore throat here. What's going on? So he actually turns up for a test. It's positive. Now, there are 2 scenarios. One is that he's one of the rare people who have a really long incubation period. It's possible in a couple of people that it's out to 17 days. But even the day 14 swab probably would start to have picked that up. And the second scenario is that he's picked it up on the way out. So they did the genomics, which is where we can tell the family, the lineage that it comes from. And it was an alpha strain, which is, the UK strain. And they went back to Adelaide and they said, dear Adelaide, could you show us your results of your genomics on your positives in hotel quarantine? And bingo, there's a match. So Dr. Nicola Spurrier, the Chief Health Officer there, apologised to Victoria. So just in case you think it's just us, we did get an apology. And yeah, he had managed to spread it around a little bit. Then you might have heard about a family came back from Jervis Bay to Melbourne, all 4 positive. No link with this guy at the hotel. I use this story to explain 2 things that can happen. 3 things. One is how useful the genomics are. 2 is contact tracing. And 3 is that, the strain type. So this family all test positive to Delta. Nothing to do with the bloke who came back on the plane. And so we had to, a little outbreak within a bigger outbreak. And that Delta one has come from, they eventually traced it back, and it did come from hotel quarantine. So before you get all upset about hotel quarantine, just accept it's a very human endeavour. You and I, we would not want to work in hotel quarantine. There's so much to think about, and we're not putting people in quarantine necessarily with 30 years experience of, barrier nursing. So it's a very human endeavour. You've got people coming back who are jet lagged, but this is what we do know. We do know that we can cope in Australia with about 2% positives. And in late April, we got up to 15%. Now that begins to really affect, surge capacity and stuff like that in our health system. Hence the flights, I think, from India were stopped. Well, of course, the Delta strain by then had spread well and truly from India, and it's now the dominant strain in the UK. And it's, I think, 25% of cases in America, in the US, are Delta. So, of course, that put a halt to the flights. That's what you really have to do. We can go on and on about how it would have been nice to see so-and-so and so-and-so and the urgency. And I know that there have been some compassionate flights granted. But the risk is the fact that we're about 8-9% covered, fully covered. And the Delta strain, it's clear that you need both doses. You get only about a 30-odd% bit of coverage with one dose. So you need your 2 doses, absolutely. So you can see the situation the governments are in. It's really not a political thing at all. It's about saying public health and how much capacity have we got in our health system, keeping people safe. The more people that you have that are positive, the greater the risk of it leaking. That's just logic. And, you can whinge and whinge and whinge about, why don't they do this, why don't they do that? At least we're accepting that COVID or SARS-CoV-2 is in fact airborne spread. Standing here this time last year, a lot of us weren't really that sure. We were teaching that it was droplet spread. So that's a segue into something I'm going to show you now about the P2 masks, which kind of really don't want you wearing, because I don't want you to put yourselves in the situation where you might have to wear one. So just to explain airborne spread, and this is what we've learned about COVID-19. And can I say influenza as well? A bit shocked to see that the immunisation levels for flu have dropped over since last year. So please remind people the last thing we need is a flu outbreak to complicate the current picture. Okay, and again, appreciating that a number of you on the Central Coast are in that lockdown. I think tomorrow's the big day for that whole Sydney coast area. I'll have a clearer picture. I mean, most of us will have a clearer picture tomorrow. Keep an eye on the total numbers, even though they say, oh, isn't it good, 35 out of the 37 or whatever, or 33 out of the 35 are known to us, they're already in isolation. That's actually not huge comfort to me, because next do we say there's 150 and 148 are in isolation, because guess what? We're finding people who are in so-called quarantine or isolation are not always doing the right thing, and you get leakage anyway. So I always keep an eye on total numbers. Same as I always keep an eye on how many coming in by plane are positive. Once that gets much above 10 or 11, it just becomes a little bit tricky. And we were getting into the low 20s when they stopped the flights from India. So what I want to try and explain is airborne spread. So this is a picture that I think you can identify with. I'm in a room on my own, and I'm chatting away to myself for some reason, or I'm on the phone, and I've got COVID. I've got COVID-19, but I'm chatting away. And as I breathe and talk, I'm emitting particles, droplets, quite big ones, and they hit the ground, about 1 metre out. Smaller ones, and they might just sort of go out 2 or 3 metres, and really little bits of spit and snot. That's what it is, and water vapour. And so the tiny, tiny bits, if you like, the aerosols, I'm not pushing them out particularly. I'm just, it's not like a nebulizer. They're just coming out all the time as I speak, breathe, etc. Well, those tiny ones hang in the air. You can imagine maybe a gas cloud. Hang. They dry off and they move around, right, with any air currents. Now, I'm in this room. It's got a window and a door, but hey, they're closed. So this gas, if you like, this air cloud has got nowhere to go. And now somebody else comes into the room. They've got COVID as well, and we're having a great chat. Can you see the cloud getting denser and denser? A third person walks into the room. They don't have COVID. What are they doing? They're inhaling. And it's a concentrated, dense cloud. That will spread COVID. And we're all 1.5 metres away from each other. So you can see distance isn't that helpful for airborne spread. Now, what if we'd all had a mask on? Yep, that would reduce the risk. What sort of a mask? Well, okay, we've all got one of these on, and it can be a little bit more risky with one of these. You can see now why on the COVID ward, they automatically wear the P2 respirator. So where it's high risk, strong suspicion that the person's got COVID, can I just say, number one, they're not coming into my practice, I'm going out to them. So that's like number one for general practice. Who's coming into my practice? We don't refuse people, we must see them. These people may need to go to hospital if they're not too flash. But if I've got to stick my head in their car, or for some reason they have ended up in my room in front of me, I've got one of these on. And I'm going to show you how to use it to the best of our ability, given that you may not have access to fit testing. So I'm going to show you fit checking, but I'm also going to really try and steer you away from even needing to wear these. That is, we see the patient outside. You know, I don't mind people wearing an ordinary surgical mask outside, but as soon as I've got to put my head in the car of somebody who's symptomatic, and please don't say, oh, it's not COVID. You know, that's what the poor limo driver said, the barbecue man, the poor guy on the plane in Melbourne. I had a swab on Friday. You know, on Thursday, I tried to talk myself out of, oh, I don't think I've really got a sore throat. You know, that day before, Friday, I just said to my husband, I'm going over to get a swab. And it was negative. Text you at 6 o'clock the next morning. But I didn't go out on Saturday because I still had a bit of a sore throat. People aren't quite engaging with a bit of infection prevention control. If you're symptomatic, regardless of what it is, really, should you be mixing with people? I don't think so. So I just said to Jenny before, one of my commitments after the pandemic is actually still to wear a mask if I've got any symptoms at all. Yeah, this is, you know, normal in some countries. So let's go back to if you're in a situation, and lots of practices have got the P2s, they just kind of don't really know what to do with them. This is for this, you know, one-off occasion where you've got to stick your head in a cup in a closed space is what I'm talking about. Outside, you've got unlimited air. You will see, it really depends state to state, but in some states, those doing the swabs wear these. In other states, they wear the surgical masks. Everybody wears a face shield. So if you're going out to the car, don't forget your face shield and your gloves. I'm not going to panic about your gown. Okay. So 2 elastic straps on it. Always do your hand hygiene. Get my alcohol out. A bit early in the morning for alcohol, but bit of a dip there into my hands, into my fingernails. This is just a reminder because people aren't doing it properly. Wet all over, no jewellery of course. I want the alcohol to get into all parts. So it needs to still be wet at 15 seconds because we need 20 wet seconds to disrupt the envelope on the virus. And guess what's associated with the envelope? Those little spikes. We don't want those sticking to your throat. So make sure it's just sticky, just going soft now. Okay, so now you can do your work. So here are the 2 bits. Now I'm going to take my glasses off only because it's easier. And here's the nose bridge at the top. I'm going to put my mouth in and one under the ear and one all caught up in my combs on the top, the crown. Come round to the front. Now, if you've got really long hair or messy hair, just wear a cap, okay? Only just to keep everything about a third of the way down the nose bridge. And you'll see that this gives you a much better fit than your surgical masks. No hair stuck in there. Now, do a bit of a yawn and press it a bit more. Now do some heavy breathing. Okay, now I can't feel any hot air or cold air, you know. So the seal is not bad, but this is not a fit test. This is a fit check. And this is what you must do every time you put on a respirator mask. So you've seen the patient, remember to cover your eye shield, etc. When you're away, to take it off, it's you grasp one band, then the other, and it's away and down and into the bin. So in general practice, you'd really only just wear it for the one person. If you're on the COVID-2 ward, you can get what we call extended use. So you can go patient to patient with it, unless of course it gets splashed or you touch it or something like that. You change your gloves patient to patient when you're on the COVID-2 ward. But for us, we would just wear that one off. So I've shown you how to fit check it. Fit testing, which, good luck if you can access somebody who can do that test for you. The hospitals have got people who, they organise to come and check. But I think one person in the practice should be able to at least fit check, like I've shown you. Fit testing is where they will actually measure the seal to your face and say, your face can form a seal on that particular brand of masks, because some faces don't work with some masks. So that's gold standard. I'm giving you, maybe silver. I'm not ashamed of that, but we do what we can do. But I can tell you that it is a risk reduction strategy to go to a P2 when you've got a suspect patient. All right. And I know there'll be people going back, maybe just grab a P2 and start practicing. You can get the videos anywhere or the instructions anywhere. And I would be just keen for people to know how to do it. This is not the last pandemic we're going to have, okay? All right, so airborne, think of that cloud, and that can remain suspended for some hours, Now let's compare that to being outside. So you decide, I think what I'll do is I'll have a little tent, an open-sided tent, and we'll see our symptomatic patients out there. And so there you've got unlimited air changes, unlimited, but there's still some risk. We found with Delta that there can be short spread. So if I've got to get up really close to somebody for any length of time, it's going to be your call as to what sort of a mask you use, but I can tell you it's lower risk. It's not no risk. So there may be some people who choose to see symptomatic patients outside with a full-on P2 mask, and others say, well, the risk reduction strategy is being outside. I've got a surgical and a face mask, and I don't stand. Once I move back from the patient, once I've done what I need to do, I don't stay any closer. The 1.5 metres I think is going to become less important once we sort of really come to grips with this being airborne spread. But of course, being up close is the greater risk still, because you're going to get a decent dose. But what I'm saying is there's an infectious dose in that room where somebody's got it and they're breathing and breathing and there's no ventilation. So that brings me now to ventilation. And I was chatting to Central East Sydney PHN last night. I had them on Zoom. And this is about opening windows and doors. And of course, they're in shopping centres. They're in, well, I don't know. So somebody told me they had rooms with no windows, and I was a bit, but I know that because it's the same in Melbourne. Now, can I just put it bluntly? What sort of an environment are you working in that is conducive to spread? So firstly, you're in a shopping centre and you tell me that there's no external door and no windows. And I'm saying to you, well, go to the shopping centre owner and say, excuse me, how many air changes are occurring in each room in my shop front? And if they don't know, God help you. So listening to Raina McIntyre last night, Professor McIntyre on the Health Report, and she said something that really kind of, I think we can, this is the language we can use. She said, you know how we demand safe water? Well, she said, I think it's about time we demanded safe air. And so we go to those shopping centres and we say, well, what are you doing, manager of the shopping centre, to ensure that you've got adequate ventilation is 4 to 6 air changes per hour, if you want to nail it with a number. And I'd be a little bit strident. and say, you know, I'm running a healthcare facility in your shopping centre and I need to know that. Now, one of the suggestions last night was I'm just not a fan of running waiting rooms at all, at all. You'll get a cougher in there, fantastic. Oh, but they've all got masks on and they're all 1.5 metres apart. Well, that just doesn't count for as much as it did this time last year with this particular strain. And the Delta strain is just so sticky for your throat, is all I can tell you. And you see that you don't need much contact at all. So what I suggested to this particular clinic, who had no windows, no doors in a shopping centre, apart from like moving, and I do know that there are practices who are really reconsidering their situation and saying, you know what, this actually isn't fit for purpose. And I am going to eventually get somebody in here with this, you know, whether we're fully vaccinated or not. And I really do want to know that I've got these air changes. So I suggested, look, generally in Melbourne, they're not running waiting rooms. You just get called in when you're the next person. And if you're symptomatic, you get seen outside generally, okay, generally. And that just depends on if there's any circulating local case. So I said, well, not knowing that they were in a shopping centre, no windows, no doors. And I said, well, put up the chairs outside. And they said, oh, the shopping centre owner wouldn't like that. And I said, well, why don't you tell them to go up and have a coffee and you'll call them? What's the difference? Shopping centre doesn't know that you're in the little cafe next door waiting to be called by the doctor. So you can't have everything, but you need to think, how can I run my practice so that people aren't gathering and are not spending time close up to others? And you might go, that is not the definition of a general practice, that is the opposite. But you can do it. So open windows and doors where you can. Don't just throw up your hands and say, I can't do anything. Check yourselves. When you wake up in the morning, like this morning, oh, I've got a bit of a throat. Have I got a bit of a cough? And can I say with Delta strain, can I say that those who are partially immunised, the symptoms are changing? And yes, you can still get COVID if you've been immunised, not as much and not as severely, but you still can get it. So the symptoms are changing. They're a little bit more about the runny nose, headache. Headache is right up the top there. Runny nose, bit of a sore throat, bit of a cough. Fever is down at about number 5, and loss of sense of smell has just almost disappeared out the door. So do you check when you wake up? Do you know what the status is of people in your household? That the 15-year-old in the cave, make it quite clear to everybody in your household that you're a healthcare worker, and that if there's anybody in your household with a symptom, there's only one place for them and you're taking them to get swabbed. That's what you do. Okay. Now, last week, one of the other Sydney PHN said, so is Mark Jennings saying that even if I've got the slightest tickle or whatever, I should get a swab? Yes. Can't say it loudly enough. Yes, and straight away. Even me, I sat on this for a day because I kind of wanted to talk myself out of it. I'm just telling you that's the human side of it. Go and get it. Go and get it done. And as soon as you get that swab done, you go home. You don't go shopping on the way home. People try to cheat, I know that. But just say to yourself, I don't want to give this to anybody else. So go home and wait for the results. And, everybody's getting their result within 24, 36 hours. It's fantastic. And, you're looking at testing in the high 50s, 50,000. So back to your practice. I'm actually going to make sure that when I come to work, I don't have any symptoms. Nobody in my household has any symptoms. Otherwise, I'm not at work. So that's for all of us. Check each other before you get in the door. Have a buddy. Mel, have you got any, any of this, any of that? No, good. Nobody in your household? Good. I need to make your workplace safe. Having said that, yes, we know that about 20% of people never get any symptoms. 20% of positives never get any symptoms at all. And it's about 40% all up who will pass it on while they don't have symptoms, okay? That other 20% usually go on to get symptoms. The figures are a bit rubbery. It used to be between 70% and 45%, of people who didn't get symptoms. But it looks like more do in fact declare some symptoms. So anyway, we know that it's at least 20% of people who will never get a symptom, but let's worry about the 80% who do. So any symptoms, not coming to work. And I think I would appreciate it as a practice manager that I'd rather be one staff down than have to close the place for a fortnight because somebody did come in and they were positive. So sometimes the staff will say to me, it's the patient. I go, no. And I've now worked with 2 clients who staff got it, okay? 2 receptionists. So let me just shine a light. And I go, why did those 2 receptionists get it? Well, you know, they tried to stay 1.5 metres apart, Marg, at the front desk. And I go, sorry, let's go back one. Why did you have 2 receptionists at the front desk? Oh, well, one's to greet the patients and the other's to take the phone calls. Why isn't the one doing the phone calls in the back room? You see how you can risk reduce? You don't need 2 people at the front. Even if you think you do, you don't. Have one on the phone out the back so that person doesn't have to wear a mask. They're in a room on their own, etc., etc. So remember, we're doing contactless. We're trying to risk reduce. I don't think I've seen cash for about 16 months. So risk reduce. They do their hands. The patients are checked before they come in. Yes. Remember when we used to think it was an intrusion in people's privacy to ask? Well, we've moved on. So patient is making an appointment and we make it clear that if they have any symptoms, let us know. We'll still see them. See, some of the patients won't tell you that they've got a symptom because they think they're not going to be seen. So no, we want to see you even more, but we're going to do it a bit differently. We'll come out to your car, we'll see you outside, etc., etc. Don't tell them to buzz off. You really do need to see them. It's good medicine. And they might have other things. I know there are little kids with snotty noses that go for the whole of winter. Little kids I kind of feel and fevers, I wouldn't want the sun to set without me seeing a little kid with a fever. So I wouldn't be pushing people away. I want to see them. I've just got to do it a little bit more creatively. So all of you will be having very different setups in your clinics, but I want you to try and adopt the really basics. Got to get some ventilation, got to get masks on everybody, got to get the symptoms sorted. And that's all of us, not just going on about the patients, that's us. If you hear one of your colleagues saying, I've just got a bit of a sniffle, I was going to say jump on them. No, move back and just say, get out of here. We don't need that in here. What have we learned? Get a bit snappy, sorry. So contactless hand rub. So the patients are cleared and you might say to the patients, this could be your setup. Look, we're not running a waiting room at present. We'll give you a buzz when you're going to be the next patient so that you're really only in the waiting room as transiting or for 2 or 3 minutes. That keeps my reception a bit safer. You've got the sneeze shields, they've got their masks on, and I'll talk about mask changing in a second, and they've just got the ordinary masks on. We've all mostly just got the ordinary masks on. And then the patients go through. Now, 2 things I want to talk about. The doctor who's stuck with the patient for a number of minutes and the receptionists. Remember, we don't want the patients in the waiting room for too long at all. Okay, so reducing. Don't sort of go into this, I can't do any of these perfectly, it's hopeless. It's about how much you can do and about how many of them you can do. Okay, we'll keep on reducing risk. This is the space that we just have to work in. And our cleaning, wiping over our high touch surfaces twice daily. People ask about the chairs and what to do it with. So you might be using your Whiteley ViroClean. You notice I don't have a spray. I've just got a flip top. We don't use sprays in. It's all white. So with a big wiper and folding it over, you can get about 10 different handles done. So I like people in their own space, like the doctors in their rooms, to just wipe over stuff that people touch, you know, all the time. Certainly their devices. Definitely clean over your device every time. Or you might use, so yes, you can use a disinfectant that also acts as a detergent. If the surface is actually dirty looking, you'd clean it first with that product and then you'd go over with a fresh wipe and leave it wet. Leave the disinfectant wet to dry. We know that a wet minute will reduce with, say, a 0.4% quaternary ammonium compound, such as in those 2 products. You'll get a 4 log reduction, okay, over a minute, which is pretty good. So you can really render the surface fairly safe. So twice a day, you know, lunchtime and home time. Don't leave it to the cleaner. You know where the high touch surfaces are. Buttons, tabs, all that kind of thing. And you just turn the thing over and put more product on as you go along each time. But you will go through a number of wipes when you do that. So that's that bit, and we can all do our own. Going back to the masks. So most of the time we're wearing a surgical mask. Whoops. I just want to show you some of the finer points. Now, no doubt you've seen a lot of people with tracheotomies lately, and they wear theirs like that. Okay, well, that's not very helpful. Okay, so then what about the mouth breathers? Got a few mouth breathers up there? Yes, okay. So this is the right way to wear it. Third of the way down the nose, press it in. Have a really good nose bridge. That's why we say wear a surgical mask. When your patients come in, give them a surgical mask to wear. Okay, it's going to be more protective for you. They come in with all their cloth bits and pieces. You might sort of say that'll send us broke, but I'm actually thinking about your safety right now. Now, you want it fairly flat at the side. You don't want that where you get a pocket, because the air, least resistance, will go in there. You want it flat. Right, so I want to breathe through here. Here are the three layers. You've seen me do this. You've got your outer one that catches the big bits, all right, colour against your looking out, and the softer one against your face. These are all, you know, blown, non-woven polypropylene. The middle layer, because we all wear triple layer surgical, feels like skin. Feels like skin. You know, if you're going to do a skin graft, feels like that, okay? The P2 has got really electrostatically charged layers in it, and it's far more, you know, we've discussed that. So for this, there's only one way to take it off. Both hands away and down, and there's only one place for it, the bin, okay? And during where you've got local cases and stuff, really it should be going into the clinical waste bin. That's that thing about, oh, we're okay here. Well, really? I don't think so. How often? Now, here's something that I think the managers can get their teeth into, and this is a little bit about mental health, but it's also about the mask itself. Once these get wet, they're not working very well. Okay, so good fit. Oh, a little trick I didn't show you was if you don't want to fog up, so good fit, and then this goes over it, you see, and you won't get fogging up. All right, but you've really got to make that a strong fit, and that goes just over it. I would strive for every 2 hours, change your mask. Why? And you might do it 3 times a day, but what I'm really getting at are my staff getting up, walking around, going to the loo, having a drink, getting outside, even going into their car where they don't have to wear a stupid mask and listen to some music, chat to somebody on the phone. I think a good manager will make sure that I haven't got somebody sitting there for 5 hours with the same mask on. So people go, oh, you know, really, I've got to change my mask. And I go, well, how else do you drink? And of course, you know what the answer is. Well, we take it out off and we put it in our pocket. No. Just remember Tasmania, this time last year, 120 cases, 12 deaths. And one of the findings was staff going to the tea room. Who's using a tea room? Staff going to the tea room and putting their masks on the table. Fantastic. So these are the tips that I need to enable for you, okay? Any questions there, Jenny, on any tricky situations that clinics have got in terms of enabling? What things would people struggle most with? I think it's the ventilation, but look at the different ways we can rejig that.
There's a couple of questions, Marg. What is time factor for infection on surfaces of COVID if not cleaned? Example, hard surface or clothing.
All right. Well, I've got some interesting news, good news in a way. Remember when we used to bang on about cleaning everything 1 million times a day? Well, kind of backed off a bit in case you hadn't noticed. So this is what we found out. The evidence is very poor for spread from environmental surfaces generally. But let me tell you where we know the risk is high, and this is where it looks like they've been able to trace it back. I'm not saying don't clean. I think it's probably less important what you clean with, but definitely do your high touch surfaces twice a day, definitely. So what we found out is that the virus can remain viable for some hours, but of course as time goes by, the amount of virus that is viable drops off. You notice I don't use the word live. Viruses aren't alive. They're just little bits of, you know, RNA or DNA that can replicate inside your cell. So a viable virus is one that can get into a cell and replicate. So as time goes by over the hours, that number drops off. And for you to get sick, you've got to pick up in there a number of viral particles. You can't just pick up one virus and sit it in there and get sick. You need thousands, okay? Even more. So if the surface then becomes less full, you know, a viable, it's just less, you can't get COVID from it. But I was going to tell you where you can get it from. I'm in a hospital. Have you got a cough there? I'm in a hospital. I'm working in the COVID ward and I've got my gloves on, and for some reason I don't take my gloves off. Oh, I know, I'm dealing with some equipment and I've got the patient, I'm doing stuff with them and I'm pressing buttons on some equipment, let's say. So I put stuff directly from the patient onto that button. I then forget about cleaning the button, take my gloves off, I go off and do, you know, something else. Somebody else comes along and don't ask me why, but for some reason they haven't got their gloves on and they go to touch that button that is absolutely loaded up with virus, you know, because it's been, it's from the secretions of that patient. That button gets touched and back to their mouth. That is where they have found it transmitted. So whilst cleaning is important, you can see we've become less frazzled about it. So right now I would be expecting you guys to be doing your normal clean each day of your normal surfaces and be doing a twice daily wipe over of your high touch surfaces. But look, if you want to look at things like HIV, if you keep it cold, you can keep it infective for weeks and weeks and weeks, but that's not in fact how we're getting it. So surface transfer, not as common as what we initially thought. Now that's not a change, that's just because we didn't know and we're looking for evidence. Of course it's possible, but you need a certain number of viral particles down the hatch, you know, an affinity for your throat or eyes actually, but more the throat. With the Delta strain, as I said, it's sticky, it is really looking for that throat. And you can see that in the shopping centre in Bondi, I think it was just 10 seconds, was it? 10 seconds, fleeting contact, enough for somebody to get a few breaths of air. And of course, you know, the virus over time will become less pathogenic, but right now we're only into the second year of the pandemic and we're hopefully not going to have a third year. And that leads me now on to having a bit of a chat about herd immunity. Now, the term herd immunity is honestly just associated with immunisation. You do not get herd immunity with natural infection. Otherwise, why would we still be getting measles? Or why would we have still been getting measles every 2 years if herd immunity was occurring through having measles? So the vaccination is what in fact brings about herd immunity. Can I also say that the immune response artificially induced by immunisation actually brings about superior protection to natural infection. Bit of a shock to some people who thought maybe it would be just better to get this. We have, of course, got cases of reinfection of COVID-19, so you can get it a second time. Symptoms are changing just like they do with being vaccinated once or even twice. And herd immunity is where the virus really just can't circulate effectively because each time it comes up against somebody else, that person is protected. That then leads to the question, can I still be infectious if I'm immunised and, you know, the virus comes towards me? What actually is happening there? And what happens is that when you mount a good immune response, and can I say, both of the vaccines are very good. I'm a little bit sick of people dumping on the AZ. I know there's a certain group who who it's not preferred for. But these are two very good vaccines, really, really good. And there's probably about another 60 in the pipeline, so who knows what we'll end up with eventually, but they're very good vaccines. Okay, I'm not going to comment on other aspects, but they are inducing very good responses. And my view from just what I can see is that the response to the AZ is probably going to be more durable, okay? Might be a longer immune response, you know, holding. Both strains, both vaccines are holding against the Delta variant, holding. Okay, so not as effective, but probably only dropped by, you know, 5–6%. So you know that we're in, I think it's the high 80s for Astra and the low 90s for Pfizer. People somehow want 100% in a vaccine. Well, good luck, because we don't have one. Measles is really our top vaccine at 95%. Okay. Now, I've got a little table. I'll be circulating it for those of you on my newsletter list. And this, I've cheated. I've copied this from Professor Raina McIntyre's lecture on immunity late last year, and it's interesting. It's still relevant. And this is, I'll just read out two figures for you, and you'll get it in a flash. It's a table that says, I want vaccine effectiveness of over 70%. Look, you need a vaccine over 70%. There are a couple of vaccines that are under 70%. I think Sinovac was passed, I think, by World Health at 51%. So we go for the over 70s, okay? So both of ours, the Pfizer and the AZ, are both over 70%. So you want over 70% to achieve herd immunity. Now, what percentage of people do you need immunised to get that? So let's say I've got a 70% effective vaccine, okay, and we know ours are more, but let's say it's been passed. I would need 86% of the population immunised. And when we say population, definitely down to, you know, 12-year-olds and possibly lower, but let's say 12-year-olds. But it just says population. So it probably means the whole population, which would mean definitely all adults. And they are looking, as you know, at the vaccine for younger kids for later on, and I think we will have to have it. If you've got a vaccine that's 80% effective, you would need 75% of your population immunised, and you're saying to yourself, that's a bit more achievable. So that's with an 80% effective. So you see, I'm going up with the effectiveness of the vaccine, and I need less of the population covered to get herd immunity. So herd immunity is where I don't get sustained spread. If I have a vaccine that's 90% effective, then covering 2/3 of the population, okay, is adequate. And if I have a vaccine that's 95% effective, which of course we'd all love, then 63%. But what I'm saying is 95%, I need 63% covered, but 90% effectiveness, 66, is only 3% difference and 5% difference in the vaccine effectiveness. Coming down to 80%, which I think is more realistic, we need 75%. So yes, it's fabulous if we can get our vaccines up. I think the Astra's around about 88 and rising. Can I just say, with the Astra, they're still picking up antibody increases at 8–9 weeks. With Pfizer, 3 weeks is about your tops. Now, don't panic and say, oh my God, does that mean after 3 weeks when I get my second shot, you know, that's after your second shot. Does that mean, you know, like it's not working? No, that's not true. Don't worry about the antibodies dropping. That doesn't matter as long as you made them in the first place. Plus, there's a cellular response, a T-cell response. I think we've now got 6 months data, and the vaccines are holding at 6 months. So whether I think they're going for a third shot in the UK around Christmas, just before Christmas time. We're in a completely different space. We don't have much natural immunity in Australia, and we don't have herd immunity. So always be careful about comparing ourselves with other countries. Our situation is very different. No other country is doing quarantine like us except for New Zealand. So our situations are quite different. So you can see why it's not the end of the world if you have a 70% effective vaccine. It's about how many people you immunise. But it's a really good little chart that. There were a couple of other things that I also wanted to mention, and I'll take some more questions, is that there are different sorts of vaccination you can have. So you can have mass vaccination, where we target the whole community. So you can see we're actually doing a bit of that. You can have targeted vaccination, and we're doing that too, because we looked at our healthcare staff, our quarantine staff, etc. So we're doing a bit of targeted as well. And then there's, and we just started to do this, I think yesterday, ring vaccination. And that is during an outbreak. So you know the aged care facility in Sydney, and they moved in very quickly, and they're doing the rest of the staff. Now, at first you think, well, what's the point? They're not going to make antibodies for a couple of weeks. But even on day 10, 11, after your first shot, you'll get a little bit of a bounce, and who knows, it might be enough to say make the illness not as bad. So I wanted to read that out, and the estimated, the group that I'm really concerned about are those who just don't make a good immune response, and probably a third of your patients who go to your clinic won't get a fabulous response from the vaccine, which is why the rest of us who do make good antibodies and good responses are immunised to protect those. People kind of don't connect that up enough. Why should I get it? I've got the right to, and I go, well, a member of the community, and what about your mum? And what about, you know, your friend's son who's a transplant? And what, oh yeah. So we work in healthcare. So you guys are dealing with vulnerable people all the time. And so they need all the protection they can get from you, because their response can be a little bit rubbish. In fact, some of them may not even be able to be immunised. So they're relying on you. So don't sort of, you know, start picking off one vaccine against the other. They're both very good in terms of the response. I'm not going to comment on other aspects. But just remember, when you've started to have one dose, and you do get COVID, if you do get COVID, the symptoms are a little bit different. They're more like that heavy cold. And you go, well, so what? But it's who you pass it on to. Okay, that's the issue. There's also, I'm going to be putting out a little bit about people who want to mix and match vaccines. That is not the strategy that we're adopting at present. You'll notice that there have been two high-profile world leaders. I've had a mix, and that's Angela Merkel. She started off with an AZ and finished with a Pfizer, and Draghi from Italy, he did the same. So 6-8 months ago, there were questions about whether that would be safe to do. There's a lot more work being done, but that's not our situation. We've got plenty of second doses of AZ, but what it looks like from the work that's being done is that where you do, and please don't run out today and say, I want to have two different ones, but it looks like the response is stronger where you do the two. Okay, so just remember, both very good vaccines. Don't panic. We don't, you know, there's no such thing as 100%, and don't think that 95% is better than 88%, which is, you know, what I get. People asking me, you know, I want to wait for the Pfizer. Well, good luck, because you'll be run over by the 20-year-olds in October or whenever the Pfizer comes in. So the other thing that people have been asking about is a shorter gap. There's really no need at this point in Australia for the gap for Pfizer, for AZ to be shortened. It's 12 weeks. I do know that people turning up for their second dose earlier generally may not be turned away in Melbourne, I know that. But really, we're not in that sort of outbreak situation, you know, big epidemic situation. And you would just, I would absolutely trust that I'll hear from a ATAGI whether they want to drop the gap with the AZ. Okay, but I'm not in a screaming hurry. So stay safe, and I'm just going to open it up for any more questions there. Jenny?
We do have one more question, and it's sort of back to what we asked before. Is there a place for Clinidet still?
Clinidet's a detergent, and look, it wouldn't be a crime if you went around and used Clinidet to do all your high touch surface cleaning, but it's cleaning. So if you want to, you know, put a bit of extra muscle in your effort, I just picked up the Whiteley because most people have it. So Whiteley is a detergent that is also a disinfectant. The wipes they have detergent activity in them. So what I'm saying is they'll clean. And if the surface is relatively clean looking, they'll also disinfect. Okay, but Clinidet, you're cleaning, you're not disinfecting, but cleaning will remove the soil, you know, the grime and the bugs that are in it, they'll largely go. So that's, you know, I wouldn't be sort of putting too fine a point on it, but I'd be saying, well, a clinic really should have a disinfectant of some type. And so I just find it's convenient if they have them as the wipes. Yeah, a lot of people have just swung over to the disinfectant wipes, not alcohol wipes, that won't work. But or a lot of people have this. So I'm not sort of like flogging anything. I'm just sort of saying this is what people have on hand. And I think the wipes, to be able to put a pack in every person's room, means people will clean. I didn't mention the chairs. I was just going to mention that quickly. Do we have to wipe the chairs after every patient? Well, you know what? Don't have chairs with armrests on them, because you will. Don't use chairs. What they're doing at some of the immunisation centres are leaving packs of wipes around and just saying to patients, when you get up from your chair, when you're called to be immunised, just wipe the back of your chair and the armrests. So that's what they're doing at the immunisation centres. Those of you who are doing immunisation, please don't turn your immunisation centre into a you know, a massive shedding event or, you know, super spreading event. People kind of get a bit lame. Oh, I'm doing the immunisations, they say. And I go, well, what's your setup? Hopefully you're not calling patients from the waiting room. We've already had one idiot turn up to be immunised in Melbourne last week, who's actually a positive case. Don't start me. And I think that will definitely have happened in Sydney, okay? People who just don't know and all that kind of thing. So yeah, we just got called from our car for the immunisation, and we just sat on a chair outside. This was actually for my flu shot a few weeks ago. And yeah, you're only in there for like 20 seconds, and that's good. Okay, that's good. And some people are immunising outside, and the pharmacists in and out very quickly. And I just don't want people waiting inside. You watch them where you can see them. Have your door open. You know, like the same things apply when you're running your immunisation. Okay. So yeah, okay, we can leave it at there, I think. But think of 3 things that you're going to do better after this morning. And I'm happy if one of those is better hand hygiene. Maybe you've gone like this. Maybe you've gone like that. You're going to do it very differently from now on. Remember, we know they're those 20 wet seconds. Maybe you're going to wear your mask better. Maybe you're going to use more risk reduction for your waiting. You know, think about that. And think about the exposure for your doctors and nurses if they're sitting in there with the patient. As a doctor, you might choose to not have that private discussion with the patient close up. You might walk them back to their car. You know, or I'll call you when you get home and we'll discuss it. So reducing the time spent in that one room. And I know that you've had a couple of cases. Now, how long, this is all stressful, how long does this remain so? Some of these things you'll just keep on doing forever because they're really good strategies, you know, like the hand hygiene, anybody with symptoms in the future, mask on or see them outside. Some of these are just really good strategies. I think put yourself in a position whereby you've reduced risk such that should a patient turn out to be positive, let's say they came in to see you 2 days ago for something unrelated, then they got symptoms the next day, they got a test, and the contact tracer, the department phoned them and said, where have you been? And they go, oh, I've been to the clinic at, you know, in Newcastle, and they call you and they say, listen, you had a case in here 2 days ago. So you go into a flat, oh my God, but have a think. If you had used all those risk reduction strategies that I spoke about, you're in a much better position for not closing down versus somebody who just, oh, well, they all pile in here in the waiting room. We do our best, but, you know, like, what can we do? We've got no ventilation and we can't they take their masks off, they don't wear them properly, and they sit in there for half an hour with the doctor. That is like close down for 2 weeks, contact everybody, $6,000 for a deep clean, whatever. Compare that to, oh, we check on people with symptoms, but in any case, we don't use the waiting room. When people come through to the doctor, it's close contact for the minimum amount of time, both have masks on. This is looking so much better than that first scenario that I just spelt out. You'll just thank your lucky stars if you've taken those precautions, and then the risk is much lower. And of course, everybody in your practice being doubly immunised isn't 100%, having had the 2 doses, isn't 100%. Vaccination is one of the strategies. It's huge, but so is mask wearing, and that's why you'll continue to wear your masks for some time until we do get that herd immunity. And then, hallelujah, we can think about just having this thing circulating in our community once we're sort of immunised. Okay, so do look forward to early next year. Okay, that's enough.
Mark, I've just had 2 more questions come through. If we can quickly ask them, we've got 2 minutes. Nurses tell me they aren't allowed to immunise outside without a doctor present. Is this correct?
Well, there's outside and there's outside. So let me tell you what it looks like at my clinic. The chair is right near the door, inside. Okay, so you're immunised inside, and then you just move to the chair outside where the nurse can see you. All right, so, we're taught to be creative. We're very creative. Yes, you've got to have the person, where you can see them, and the doctor. So I'm not sort of saying necessarily immunise outside, but a number of people do, and the doctors themselves immunising patients, and just say, this is a whole lot safer for me to do it in my little open-sided tent. So it's horses for courses, but yeah, that's fair enough. Some people have been immunised in cars because they just can't get out, but they've got to be within sight. So, you've got to think about that sort of a rule. So you might send the doctor out to the car for that. I mean, it's quite disruptive. Everybody will know how disruptive it is being able to offer their vaccines. At my clinic, they were quite happy that they're only getting 50 a week because the logistics of putting on more staff and the logistics of running it. So in the end, I just went to a vaccine hub near us at the hospital, and it was just brilliant. It was run like an incredible military operation, and it's 9 weeks tomorrow. If I was a really pushy person, I'd go and get my second shot tomorrow, but I don't want to put that sort of stress on the authorities. Yeah, so absolutely take notice of the advice you're given, but just think about how can I do this creatively so I can keep getting the throughput in that time allocated, and I can do it safely and keep an eye on people. But yeah, doors open, fantastic, fantastic.
The other comment was that it's just the patients have to wait 15 minutes after their vaccination, and it's impossible to watch everyone outside in winter, makes it a bit more difficult. This is from a nurse in Armidale, where it is very
good on it. And it's free. I know, well, listen, I'm in Melbourne, it's cold. But I'll tell you what, I hear them barking at people at the clinic. No, sit here. Yelling at the oldies. No, sit here, you're too far away, I can't see you. And as I said, the odd person who just can't get out of their car, and what's the alternative there? You've got to go to their house and immunise them or something. So we can push it, and it's essential. That 15 minutes is essential. You know that the cases of anaphylaxis, all except one, occurred within 11 minutes. Okay. So that's really important. With the flu, because people go, what are you here for? I'm here, this is the flu clinic, right? Okay, I can be a bit slacker with them maybe. So I'm really absolutely thanking those of you working in general practice, because I tell you what, nobody signed up for this, and yet this is probably medicine at its best. And I mean, like you, I get a little bit angry at people who want everything yesterday. You would be, both my husband and I worked in the, medical research area and teaching, etc., for years and years and years. And when you see how it's funded, and then you see the expectations of people, and can I say, with the funding that's gone into COVID, it's basically come out of a lot of other research programs. So, that's just the way it is, and is it valued in Australia? We can be proud, I think, that we're making AZ, and we'll go on to make messenger RNA, in the next while. One other thing, just to counter people who say this is a new vaccine, can I just say 2 billion doses later, this is probably the most scrutinised vaccine we have ever had in history. Don't worry about the fact that it's 6 months. The fact is 2 billion doses in 6 months. That is really something for humanity to be proud of. Unfortunately, humanity and people who should have known better didn't take on the basic precautions we've known about for 2,500 years, and that is to quarantine when you might be at risk and to isolate when you are sick. Those things have not changed, and they are the things that helped us in Melbourne last year get through our pandemic. There were no therapeutics. I was hoping that we would have a lot more therapeutics by now, and people talk about ivermectin, etc., but I'm no expert on that. But I would really have hoped. I think the dexamethasone and the proning in ICU, hopefully we won't be seeing deaths from this outbreak in Sydney, hopefully, because we've learned a lot more on how to manage people with it. But I'm pretty sure that you will get 1 or 2 deaths from this outbreak.
Thank you so much, Marg, and I certainly didn't think that 12 months later that we would still be chatting to you, but I'm very glad that we do get to see you, and thank you so much for giving us this update. I think it all just reminds us to keep being vigilant. And medicine at its best, what a positive note to end today's webinar. Thank you so much.
Okay, thank you everybody, and stay safe.
Bye everybody.
Bye.